Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 9, which is all about the mental status examination, otherwise known as the MSE. The mental status examination has held a revered place in psychiatry and medicine. It's also of growing importance to counseling, psychology, and social work for a number of reasons. So, this chapter is going to focus on the basic components of a mental status examination. So by the time you're done watching this video, reviewing your PowerPoint, and reading the book, you'll be able to describe a mental status examination and brief MSE reports, including what they look like and what's included in them. Identify and manage individual and cultural issues during MSEs. List and describe the basic components of a typical mental status examination. And identify when you do and don't need to administer a complete mental status examination. So, what is a mental status examination? When we think about what an MSE is, something for us to think about is that this is a semi-structured interview that facilitates and organizes how we look at clinical observations that pertain to mental conditions. When we think about the MSE, it is going to describe the mental state and behaviors of the person being seen. It includes both objective observations of the clinician and subjective descriptions given by the client. The primary purpose is to evaluate current cognitive processes. So, when we think about this, it's a method of organizing and evaluating these observations during an interview, and it's extremely common in medical settings. It results in usually one half-page long paragraph describing the client's mental status. So why do we actually use them? The MSE provides information for diagnosis and assessments of disorders and responses to treatment. A mental status examination provides a snapshot at a point in time. If another provider sees your client, it allows them to determine if the client's status has changed without previously seeing said client. In order to properly address and assess the MSE information about the client's history, it needs to include things like education, cultural factors, and social factors. It's also important to ascertain what is normal, quote unquote, for the client. For example, some people always like to speak first. So those are things that are going to be mentioned in a mental status examination. So this is an example of a mental status examination, and this is the about half-page long paragraph that is being reported. So let's read this together and think about what's there and what's not. Gary Sparrow, a 48-year-old heterosexual white male, was disheveled and unkempt upon arriving at the hospital emergency room. He wore dirty khaki pants, an unbuttoned golf shirt, and white shoes. He appeared slightly younger than his stated age. He looked agitated, frequently standing up and changing seats. He was impatient and sometimes rude. Mr. Sparrow reported that today was the best day of his life because he had decided to join the professional golf circuit. His affect was liable, but appropriate to the content of his speech, i.e., he became tearful when reporting he had bogeyed number 15. His speech was loud, pressured, and over-elaborative. He exhibited loosening of associations and flight of ideas. He unpredictably shifted the topic of conversation from golf to the mating habits of geese to the likelihood of extraterrestrial life. Mr. Sparrow described grandiose delusions regarding his sexual and athletic performances. He reported auditory hallucinations. God had told him to quit his job and become a professional golfer. He was oriented to time and place, but claimed he was illegitimate son of Jack Nicklaus. Jack Nicklaus is a famous golfer. He denied suicidal and homicidal ideation. He refused to participate in an intellectual or memory-related portion of the examination. Mr. Sparrow was unreliable and had poor judgment. Insight was absent. So again, when we are thinking about the individual and cultural considerations, especially after viewing the report on Mr. Sparrow, it's really important for us to think about things objectively. Your total objectivity is impossible, but it's important for us to be as objective as possible. Your mood and beliefs can interfere with help with your objective mental status evaluation. So, if you find that your mood and your beliefs can interfere with your ability to provide an MSE, it's important to work through those things with your supervisor and or external supports. Be sure to keep your emotional sensitivity in your MSE processes. It's also important to keep in mind the many ways that individuals vary in their behaviors and their abilities. When you think about normative behavior, what happens within one culture may not be acceptable for another culture, and another culture might be considered disturbing or irrational. So it's important to make sure that we examine those things as well. So, what are some of the dangers of a single symptom generalization? So, some things that we need to think about with this is that as we are examining that, when we are examining some of the common single symptoms that clinicians may be prone to overinterpret, it's important for us to think of it from this perspective. Your clients might be presenting in different ways. And remember that this is the intake interview. So they are not going to be functioning at their best. They may find when they first come in that their speech is more pressured and their thoughts might be more racing. But as they become more comfortable with you in the process, you may find that their thoughts aren't as racing and their speech isn't as pressured. So it's important to note that you might find fluctuations within this mental status examination. It's important to note this so that if someone else were to read your notes and have to see your client for whatever reason, then they would be able to see if there's some improvements that have been made, or if there are some concerns that are being raised, or if this behavior that's being exhibited is within the normal limits of this client. It's also important for us to make sure that if we have any bias, that we address those before we come to our sessions. So an example might be if you are someone who has a family history of substance use disorders, and maybe yourself, you might have had a substance use disorder. What we might see in our clients might be something that shows that there could be a potential substance use disorder occurring, but we can't say for certain that that's the case. So when we think about someone who is intoxicated, they might have slurred speech, they might have racing thoughts or pressured speech, or they might be really relaxed and almost falling asleep. You might find that your client is presenting this, but we can't make the assumption that that's directly due to a substance use disorder. It might have been because they have had too much caffeine, or they might not have had enough sleep the night before. When it comes to looking at overconfidence in our judgments, we might get to a point where we're like, well, we do this all the time. We see people like this all the time. We know more because we've had more experience with a larger number of people and these symptoms. So I can already tell you that this is what the presenting problems might be or most likely are, and these are what some of the disorders are. But we can't really do that because, again, this is the intake interview. You may find, again, that people present in different ways. And as they become more comfortable with you or the clinician that they're going to be seeing, as well as speaking through the intake interview itself, that their demeanor might change or that they might open up more or they might close up more. So it's really important for us to take our judgments and leave them at the door. That as we are looking at the clients that we're going to be seeing before they come in the door, to make sure that we're looking at them with a fresh set of eyes and an open mind as much as possible. When we think about the 3 guidelines, something that is important for us to think about is that we need to make sure that we are when we're spotting a single symptom of interest, begin looking at this from a scientific mindedness perspective. Think of the scientific method and try to be as thorough as positive with that. Remember that hypotheses are not in fact conclusions. If you think about the scientific method, you start off with an observation typically. That observation leads to questions. Those questions then lead to reviewing the literature. Reviewing the literature then leads us to coming up with hypotheses. You then take those hypotheses and you come up with a test. You complete the test, you analyze the outcomes, and then you present them to the public. What you have hypothesized may not be your conclusion. The same thing with our clients. We want to make sure that as we are getting information, that we are utilizing questions that will help us to better understand who our client is and what they're about, especially in the intake interview. And that if there are symptoms that are happening, that we ask them questions about things like, when did those symptoms start beginning? What is the duration of these symptoms? How long has this been occurring for? Does it occur at specific times with specific people in specific places? Um, have they noticed any changes in these behaviors? Have they gotten, better or worse? Or have they increased or decreased? We want to ask these types of questions so that we get the best understanding of what's happening for our clients. Lastly, don't make these wild inferential leaps without consulting first. So don't tell your client that they are exhibiting signs of schizophrenia when they might not be exhibiting these signs of schizophrenia. Just because they are reporting hallucinations, for example, it might it might be along the lines of schizophrenia, but it may not be schizophrenia. They may have something else happening. It might be, it might be another diagnosis, or it might be brought on by something that is chemical or biological in nature. So these are things that we have to explore before we make these wild assertions. So take this information again as an information gathering tool. All right. So now, what is part of the mental status examination? So, the mental status examination, just to kind of think about this for a second, it's going to include things like appearance, behavior, or psychomotor activity, the attitude towards the examiner, affect and mood, speech and thought, perceptual disturbances, orientation and consciousness, memory and intelligence, and finally, reliability, judgment, and insight. Attached to your module is a copy of what the MSE looks like. I encourage you to pause this video to go take a look at that MSE, download it, and print it out if you need to. As we go along, this will help to make sense. So the first thing that we look at is appearance. What do you see? You're looking at things like their build, their body, their posture, how they dress, their grooming habits, any prominent physical abnormalities. Um, what is their level of alertness? Are they um, are they displaying emotional facial expressions? Are they do they have any things like tattoos or body markings? Those are the types of things that we look for in the appearance. When we look at behavior and psychomotor activity, we're looking at things like eye contact. Example, is it poor? Is it good, or is it piercing? Are we looking to see if it's excessive or limited? We're also looking at, again, that psychomotor activity. This is either things like retardation or agitation, in the sense of things like handwriting. Are they able to write really fast, or do they not have the ability to write at all? We're also looking for movements, things like tremors or abnormal movements, like does this person walk with a gait? What is their posture like? Are they grimacing, or are they fidgeting? These are the types of things we look at for behavior and psychomotor activity. When we look at the attitude towards the examiner, that's you, the interviewer, we want to see how they are operating towards you. Are they cooperative or uncooperative? Are they hostile? Are they open? Are they more closed? Are they suspicious? Are they flirting with you? These are all things that we look at when we look at the attitude towards the examiner. When we think of affect and mood, this is the emotional state that we observe. So we look at the type. Is it euthymic, which is normal? Is it dysphoric, which is depressed or irritable or angry? Is it euphoric, meaning elevated or elated? Or is it anxious? We're also looking at the range. Is it full, which is within normal range, or is it restricted? That could be blunt or flat or even liable, fluctuating. We're looking at congruency. Does it match the mood? So is the mood congruent, or is the mood incongruent with what the client is saying? And finally, we're looking at stability. Is it stable or is it liable, meaning that it fluctuates? When we look at speech, we're first going to look at speech and then we're going to look at thought. But when we look at speech, this is evaluated typically on the rate, meaning the speed. Is it increased and pressured, or is it decreased and monosyllabic, or is it latent? We're looking at rhythm, or the how they're articulating. Is it monotone and slurred, or are they clearly talking and speaking? We're looking at the volume. How loud or soft are they, or are they mute, not talking at all? Finally, we're looking at the amount or the density, including the content. Is it fluent? Is it not? We want to look at those things to see what is actually happening. Then we look at thought. And when we look at the thought process, we're describing the rate of thoughts, how they flow, and how they're connected. So they could be essentially normal or abnormal. So normal is logical and linear and coherent and goal directed. Abnormal would be where there's associations that aren't clear, they're not organized, they're not coherent. This could be things like circumstantial, tangential, loose, flight of ideas, thought blocking. We also want to look too to see, again, when we think of that circumstantial piece, this is, are they able to provide, do they provide unnecessary detail, but eventually get to the point? Tangential is where they move from thought to thought that relate in some way, but never really get to the point. And loose are illogical shifts between these unrelated topics. Flights of ideas is where they quickly move from one idea to another. You often will see that in things like mania. Are they thought blocking, where their thoughts are interrupted? Are they randomly speaking words, which is what's called a word salad? And again, when we think about these things, we want to take into consideration that there could be a number of factors that are interrupting these thought processes. Now we look at thought content. And this is going to refer to the themes that occupy the patient's thoughts and perceptual disturbances. And they're going to include essentially delusions, obsessions, and suicidal or homicidal thoughts. So when we're looking at perceptual disturbances and we're looking at things like hallucinations, illusions, and flashbacks, we are looking at, are they, is there, with hallucinations, this can occur in any sensory modality, but are most commonly auditory. Do they have these false sensory perceptions? Do they hear things that others can't see? Again, that's auditory. Do they see things that others can't see? That's visual. Do they touch? Do they feel things touching on them that others don't feel? That's tactile. When you think about illusions, they have some basis in reality, but are not really full of reality-based things. When we think about flashbacks, these are sudden and vivid sensory-laden recollections, or recollections rather, of previous experiences. And those recollections are typically brought on by a trigger of their sense that is connected to whatever that traumatic event or events are or were. When we are asking about perceptual disturbances, we can do a couple of things. We can grease the wheel. That is to help the patient feel comfortable by sharing the information through kind of going through it with them. You can uncover the logic that's associated with this delusional material. And the logic may not make sense to you, but if it makes sense to them, then you can start putting some of those associations together. You also want to determine the client's insight and how much distance they have from the symptom, meaning how often does it occur, what causes this to happen, etc. Let's kind of go back for a second. When we talk about obsessions, we are looking at essentially, do they ruminate on different things? Do they consistently think about the same thing over and over again? You try to switch to a different topic and they come back to whatever it is that they're kind of ruminating on. That would be an obsession. When we talk about suicidal or homicidal thoughts, this is part of preoccupation. And when we think about this preoccupation, it could be something that is more overt or not as overt. So it might be a little bit more implicit, but it's really important for us to be able to start thinking about this. We also want to look at things like the ideas of reference. This is misinterpretation of incidents and events in the outside world that have these direct personal references to the client. So an idea of reference might be that the person believes that the presidential election could literally, the outcomes could literally be the end of the world, and that the world is going to end on, November 4th, and that their preoccupation with this could, and their ideas of reference could be misled because they had heard somewhere, maybe on the news or in social media, that if a person doesn't win or if someone does win, that it could be the end of the world, and they take that literally. There's also derealization. This is the feeling of the outer environment that doesn't feel real. So this might be someone who maybe engages in dissociation, who doesn't feel like the world is really going on around them. And then you have depersonalization, and this is the sensation of this, reality that is false, that concerns themselves or parts of themselves. So in depersonalization, they might not have a really, they might have a hard time connecting to their being. They might think that, they are really more masculine, but they're presenting and identifying as feminine. You sometimes see this with people who have gender related concerns, where there's this depersonalization of themselves, because even though they are presenting or have a name or are expressing themselves in a somewhat feminine way and might be biologically female, that they start depersonalizing and really starting to embrace that masculine or male side of themselves. So you might see that occurring as well. When we think about orientation and consciousness, this refers to the client's awareness of themselves and the situation. So you want to find out if they know the date, the time, the place, the situation. Do they know what brought them here? If they don't know what day it is, if they don't know who's the current president, if they don't know what day of the week it is or what time of day it is, that's something that you need to note. When you talk about consciousness, this is rated from alert to comatose. When we look at orientation, we are essentially looking at, things like, what are your name? Where are you? What's today's date and what's happening right now? When we look at memory or we look at intelligence, we are essentially assessing, um, what is their level of thought processes. It's kind of risky to assess this when you do a short interview, which most mental status examinations are going to be a little bit shorter. A full mental status examination may be a little bit longer, but if it's something that's happening in the short term, you might want to be neutral in assessing memory and intelligence because you might not have gotten to know the person better, but it's something that you can answer once you start getting to know them better. So the initial interview or the intake interview might not be the place to really start assessing this unless there are clear and marketed signs. For example, if the person who's coming to you has come from another agency or has come from something where it has been clearly identified that this person does have an intellectual ability that is differing. So if it's been documented that this person does have mild or moderate IDD, then that's something that you can then document. But just because they have mild or moderate IDD, that's intellectual or developmental disability, just because they might have that as a diagnosis and they might report that to you, that still doesn't mean that their intelligence is low. Because with many individuals who do have IDD, whether they're mild or moderate, they might be proficient in certain areas. The MSE can show their proficiency. For example, I did have an individual that I saw many years ago who had mild IDD, but knew every episode of the what is it, American Bandstand? Is that the one with Dick Clark? Anyway, it was Dick Clark. He was the host of some show on TV. And I guess I should know the show and I forget, but he knew the airing date of every single show of when this episode was. So if I were to look it up, say online, and ask him about, season 5, episode 8, this individual could tell me what day it aired, which is unique. But that doesn't mean that this person overall doesn't have intelligence. It just means that he has areas of strength or she has areas of strength, and then they have areas of difficulty. Typically, you only want to provide general statements. When we think about memory terminology, there's a couple of things that we can think about. So, confabulation refers to the spontaneous and sometimes repetitive memory fabrication or distortions that can occur. When clients acknowledge memory problems, this is what's referred to as subjective memory complaints. And pseudomentia is used when depressed clients with no organic impairment suffer from emotionally based memory problems. Again, thinking about memory and concentration, we're actually going to do this in class. So take a look at this and just know we're going to be doing it in our next class. When we look at reliability, insight, and judgment, reliability refers to a client's credibility or trustworthiness. Judgment is the ability to anticipate the consequences of one's behavior and make decisions to safeguard their well-beings and that of others. Insight is awareness of one's own illness and/or situation. So, when do you actually use a mental status examination? They're typically going to be more appropriate as the client's expected level of psychopathology increases. They must be used with great caution, especially when working with culturally diverse clients. As I said in the beginning of this presentation, what might seem to be within the normal range in one culture might not be in another. And like all evaluation procedures, the mental status examinations are culturally biased in one way or another. So always remember that. I hope that this was helpful for you. As always, if you have any questions, comments, or concerns, please feel free to reach out to me. You'll also note in the module, there's a breakdown of the different definitions of all of the things that are related to the mental status examination. After you print out the mental status examination, I encourage you to take a look at that vocabulary list, which can help you to make better sense of how you would evaluate a client. We will also be reviewing this in class together. Don't forget, in the description box below is an extra credit question. Make sure that after watching this video, you answer in the comment section, take a screenshot, and upload it for extra credit. And don't forget, it's due by Sunday at 11:59 p.m. I hope that this was helpful for you. As always, feel free to reach out to me if you have any questions, comments, or concerns via email. And until next time, take care and be well.